My name's Natalie Foley. I'm the Deputy DIPSI for North West London Integrated Care System. I'm here representing us as a system, but also to cover our interface with NHS England. So I don't work for NHS England, so I'm not going to try and tell you all that they do, but it's more focused on the interface we have as a system with our regional team. So most of you will have some interaction with your colleagues. So NHS England, they've got 7 regions. I'm in London, so we have 5 ICSs within our London region. And it's actually, the talk I want to tell you about today is actually how we are changing. So in North West London, we're a little bit more mature in our ICSs than other organisations are. Our IPC team actually moved into the ICS from the CCG back in December 2020. I understand from a lot of my colleagues that you're still in that transitional phase, and those of you that have been NHS long enough have been through many a change. I think we're still going to be changing in the future, but I'm quite excited about us going into the ICS. So I'm not going to talk to you too much about NHSE, you understand their function, but actually it's how we as an ICS now are taking on some of the functions of NHSE, but how we continue to work. And I've got a slide further on which shows the integrated care boards and the CQC and NHSE. So this is me, so North West London. We're quite a big ICS, as you can see from our map there. We're one of the 5 for London. We've got quite a diverse area. We've got 2.5 million as our population. We've got 360 GP practices, and we have Ealing as a borough, which has our highest population. It is quite diverse. It's quite challenging as well. We have Heathrow inside our patch, so you can imagine at the beginning of the pandemic, we got very excited very quickly with all the flights coming in and us pulling people off flights, etc. But it is diverse. So this is our deprivation, I think is the best slide. So we've got some very nice areas of London. We've got Chelsea in our area, and we've got some quite deprived areas in our outer boroughs as well. So we're a big system, so us trying to work as a system is going to pose a little bit more challenges. Within that, we also have 8 boroughs, so 8 local authorities that are going to come into our system. So if I just go back to my previous slide, should it come back? So within our system, we have some providers as well. So we have Imperial, we have Chelsea and Westminster, London North West, we have West London Healthcare, CNWL, so CLCH, Hounslow and Richmond Community Trust, and we also are the lead commissioners for London Ambulance Service. So we have lots of different providers. That's just our acute providers. We also have our primary care, and going into the system in the future, we're going to have our pharmacy, optometry, etc. So that's us in North West London. So what are integrated care systems? So the whole idea of an integrated care system is we are bringing everything together. So some of you may know this already. You may be working in a system, you may be working through plans. You may be further ahead than we are at the moment, but we've done a lot of work, and I feel like I'm currently in a situation where I actually understand the landscape of where we're going. I haven't really grasped it all the way through the pandemic, and our role in IPC has changed. I've come from CCG, where we were pre-pandemic, we were going through a merger of 5 CCGs and 3 CCGs into 1 CCG, knowing the ICS was round the corner as well. So for those, I'm sure if you're outside of the acutes, you've had lots of change as well over the years. But this is the most exciting time for us, and I'm really trying to champion in keeping IPC at the forefront, keeping it at board level. Now is our time to strike, to keep IPC up there, and that's why I want to share what we're doing in North West London, and hopefully you can either share your experiences with us. You may think I've got it completely wrong, you may think we might be on the right tracks, but actually the key thing is actually to bounce off each other and actually as we go into this new world. But my biggest ambition is to make sure that IPC remains at board level when the pandemic disappears, because we've got lots of other things we need to be dealing with. So it's to work, basically it's to bring in everyone, so our local authorities. This is something good that's happened from the pandemic, is actually we've worked really quickly as a system. So I tried to engage pre-pandemic with my local authority kind of counterparts, and it was so difficult to get 8 boroughs into a room with our acute providers to actually talk about strategies that we need for North West London. Unfortunately, we were flagged pre-pandemic as the 5th highest in the country for E. coli's, and we need to do some serious work with it. we are a big patch as well, so that was really troublesome. We just started to get some traction, we just started to get some buy-in, and then the pandemic came. But actually, rather than be a negative, it was a negative for our E. coli's because we weren't able to continue that work at the time, but it was a positive that actually people I was trying to reach out to pre-pandemic, all of a sudden we were having that engagement. It was about COVID, but we were supporting each other. And actually, I'm really trying to focus on continuing those relationships and building them. So we have to take some positives out of the pandemic. So the key thing is it's going to be better for our patients. Our patients should be able to move seamlessly through our systems. Equitability as well. We need to make sure that every patient has equal opportunities for the same healthcare provision. So that is, I'd say, the most important part, but also making sure that we include our mental health as well. It's not just acute, it's not just GPs, it's everyone within our systems. So you may have seen this is from the King's Fund. This is a good description because we use a lot of acronyms, actually what the new world is going to look like. So right at the top, we've got NHS England and the Care Quality Commission. So obviously you know their roles. But actually the next bar chart down is integrated care boards and integrated care partnerships. And again, we're very free in using ICBs, ICPs, and I have to really think which one are they talking about. But the best way, kind of in quick terms, is integrated care board is similar, but not the same, to what our CCG is. Lots of CCGs are going into the integrated care boards. The integrated care partnerships is where more the local authority public health sits. But the key thing is that we are bringing these two services together for the best for our patients and our population. Going further down, it's then broken down into geographical footprints. So we've got our system, again, which is covering our biggest patch, our place and our neighbourhoods. So our neighbourhoods tends to be our primary care networks, going right through to our provider collaboratives. There is lots of crossover in this. I think this will change a little bit as time goes on. And the biggest problem we've got is actually changing from our current structure into our new structure. If you do a similar role to me, you may be fed up at the moment of keep being asked for different slides for different meetings because we're going into a new world where we're having new meetings and different people, but we're not letting go of the old stuff either. So actually our workload is doubling. And I'm constantly moaning, saying, I'm not producing any more slides. I'm so fed up of kind of doing different slides for different people. I'm going to produce one set of slides per month, take what you want from it. So I'm getting a bit moody, I think, as we're going on, but that's the way we need to be. This is our time to actually start creating what we think is right. And we don't want to be going to meetings unnecessarily and producing slides unnecessarily. We have other objectives to do. So there is more information on the King's Fund on ICBs, ICSs, ICPs, and where you sit. So I think if you are interested in that, this is a good form to look at. So what will it mean for our residents? So it basically means that they should feel supportively. We're trying to bring some of our healthcare outside of our acute trust back into the home, making sure we've got equal provision, making it the best possible care for our patients. So if you live in inner London and you're near one of our big hospitals, you should have equal rights to your treatment. If you're on the outer parts and the more rural parts of our ICS as well, you should have that same provision in place. And hopefully, I mean, this is the best way to be, that actually we're all talking to each other. It sounds a lot easier than it is, and I think it's going to be a lot harder than we make out it's going to be, but hopefully we've making some good inroads here. So this is my main function of my role. So what is function of IPC and the ICS? I've been very lucky when I've been working with NHS England. So Gaynor and Linda have been supporting me to actually refocus. The issue I had is I was in the CCG for quite a few years. I worked in different CCGs around the UK. But when the pandemic came, I lost my commissioner head, and all of a sudden I started turning to provider. Because we were plugging gaps, we very quickly learned that there wasn't enough infection control people around. So we became the doers as well as the commissioners. And I lost my mindset. So actually now we're coming out of the pandemic, we're looking at our work plan, our strategy for the ICS and the IPC team. I was still going, oh no, we'll still provide trained primary care, we'll still do this. And Linda and Gaynor were very quick to say, no, you cannot provide and you cannot commission. You can't do both. So actually it was quite reassuring. It was a reset that I needed. And actually, no, it's not. The biggest issue I've got now is telling other people we're not doing that anymore because we have done it over the last 2 years. It was a call to arms. So if someone needed help, we jumped in because we were IPC and it benefited the system. But actually going forward, different parts of the organisations need to have their own IPC support who feed into us, and we are that strategic overview. And that is probably the biggest selling point I'm trying to do for our IPC team. It's strategic leadership. We are not a provider of services. If something IPC is needed for North West London ICS, we will then look to provide that, but we won't be providing it ourselves. We'll be commissioning it, or one of our QTs will be commissioning it on behalf of the ICS. So, bringing in GPs, social care, primary care, pharmacy, dentistry, optometry, they will all need their own IPC. So in our acutes, they're quite good. They've also got IPC teams working really, really hard. But actually in primary care, it's a bit, I think the term is iffy. Some of our primary care networks, our federations, have got their own IPC nurses. I say IPC nurses, IPC leads. Some of them need quite a lot of education to bring them there. It's a new role to them. They've done a bit of training during COVID, and now they're the leads. So I'm trying to support them to ensure them actually it's not just about COVID. There's lots of other things. We've got a big problem with E. coli. You need to be putting that into your work plan. And then we've got other parts, other federations, other boroughs that haven't got any support for primary care. So I'm lobbying at the moment. I'm going up. So we've now got a chief nurse for primary care who started on the 1st of April. I was on a hotline saying, okay, welcome, nice to have you in post. You need your own IPC nurse. And of course the question is, why aren't you supplying that? Because we're not a provider. But actually what we can do is we can support you in the recruitment, we can support in the education, they can feed into us, but we will not be supplying training to you, which we have been doing over the years. So it's a change in that mindset again. And then we've got to think about pharmacy, dentistry, optometry, which are coming in as well into our remit of primary care. Actually, how many people do we need? What level of service do they need? Is it just that we're having someone to answer the phone to them if they've got any queries? Are we expected to go and do audits, training? What assurance do we need to get? So we're trying to tease that out as well. And the next question is, who's going to pay for it? Because it's not coming out of my IPC budget. So that's the next challenge that we're having. But these things need to be in place. So I'm having lots of unpopular conversations at the moment. But I need to make sure that going forward, people know our role of IPC in the ICS is a strategic function to drive, to influence, to report, get assurance, and then we have everyone else that aligns and basically make sure we're all singing from the same hymn sheet. So we all meet together. So we have quite a good structure in North West London. I'm very proud of my organisation. I'm not sure you can tell. I have my moments where I moan a lot, but mostly I'm really proud of it. So we have a North West London IPC group. It's got currently 54 invitees to our group. It's quite a big group, but it's really, really useful. We have some very challenging conversations sometimes. We were originally meeting once a month. Obviously, during the pandemic, we were meeting more frequently. We're still meeting every week. We're doing a big piece of work at the moment about implementing some regional spring guidance. So we're changing our isolation and our testing and our pathways as well. So we're meeting regularly to make sure. But I see it as a support. When new guidance comes out, firstly, we need to make sure that everyone gets the guidance so we all know something's changed. But then we have this meeting and we have lots of different people with different backgrounds that actually are able to challenge it. We don't always agree with the guidance that comes out. But what we need to have is that open conversation and feel supported. And I think that's probably the response I would get if I asked all our attendees to our meeting. It's a support. We've got some really strong organisations who are there and very present, but we also have some kind of smaller district hospitals that have lots of challenges and feel quite isolated and alone. And by us having these meetings regularly and airing concerns and actually sharing the work as well, so they're feeling a lot more supported than they did before. So that's our main group. We do want it to grow as well, but obviously too many cooks sometimes, you know all that. So what our group does, we feed into our clinical quality leadership group. So any decisions that we make, we then have to then forward on. Sometimes it goes to our Gold Command. Our Gold Command meet once a week. It tends to be chief execs, COOs, infection control, leads, etc., whoever needs to be there, directors of nursing. So whatever outcome or output we have from our meetings, if it needs sign-off by Gold, we take it then to Gold and present it there. Sometimes we take it to chief execs, and sometimes we have to take it to our clinical ethics advisory group. If it's outside of guidance and we're still not quite sure, we take it to these groups. So I feel like we're quite kind of further along our line by having these groups, and it gives us as a system, an infection control group, that reassurance that it's not just us as IPC making decisions, we've actually got other functions. And sometimes I throw things out. So something comes in, everything, as you know, always falls to IPC. It comes in, I go, no, that is not IPC. Someone else needs to make that decision. Otherwise, we're always the bad guys, aren't we? Saying IPC said you can't do that. So we say, no, that is not IPC. So that's something I'm really trying to work hard on. And it's not always very popular. I've said, no, that's not IPC. That is health and safety. That needs to go to our clinical quality group. That needs to go to our chief execs. That's not our decision to make. And obviously, we have a really good group. Sometimes we have this really good group, and we take whatever output, whatever's asked of us, we take it back to Gold, and they don't like what we come out with. And then they go, well, no, we want it to go back. And we said, well, what's the point in having this group of all your local experts? We've got public health there as well. If you ask us a question, we give you an answer, but you still don't want it. So sometimes we have that battle as well, which is why I'm really confident that I need IPC to stay at that top board level, so we constantly have that champion there. So we have NHSE as well, part of our group. So some of the outputs we have, sometimes we can't agree in our group, which is normal. That's the part of having a good kind of conversation. So what we would do is, if we don't know the answer, if we can't agree, we'll take it to our regional NHSE lead. Ours is Sally Kingsland, supported by Nicola Sirin. So we take it there. We have monthly meetings with NHSE as well, which is really useful with our counterparts within the other ICSs. And again, sometimes it's up for discussion. We discuss different things we're doing. Sometimes we do collaborative working with other ICSs. So we currently are working with North Central ICS with Marissa Alexis, developing our strategies and actually what our teams would look like going forward as well. So sometimes having a colleague, a neighbouring ICS, it helps. And we can do cross-ICS working, because sometimes it's not going to be worth us doing something and funding it when everyone else needs it as well. So why can't we do it with other ICSs or across the region? So, current responsibilities. So, I'm sure, again, you do a lot of this. So, analyse data and report to board, chair the ICS IPC group, attend regional meetings and AMR meetings. We try to enhance our relationships with meds management, encourage system working, support organisations' difficult time. This is, again, something that we were doing during the pandemic. We were parachuting our team in. When one of our organisations got into a difficult situation, whether it be CQC or HSE turned up and uncovered something, or whether they had a high level of sickness within an acute trust, we would actually parachute in as a team and actually drop an IPC nurse into that team or support them while they didn't have any leadership until they recruited or someone came back from leave. Though that kind of fits under the provider, we will still continue that provision because it's about system working. And actually, if our wheels fall off in one of our services, it's going to impact us as a system. So it's really important, even though that's not strictly our role, we will still have that function within North West London to go and support. Also, if they want to do initiatives, so if they want to roll out something related to IPC and they need more staff, if they want us to come and do audits with them so they've got fresh eyes, we're more than happy to do that because we want to be that critical but supportive partnership as well. And we'll gain learning from it as well, which we can then take to other organisations. So develop the ICS structure, which I'll go on to in a moment, strategy and work plan. And we have a London reference group where it's different people within London. We come together and actually sometimes create our own guidance that gets signed off by NHSEI, and sometimes we just discuss current problems that we have. But it's a really good support, and it really is about that system working as well. So it's not only us within North West London, we're actually talking to our colleagues in other organisations. So, future of IPC. So AMR, we have dropped the ball with AMR. We are just starting to get to the stage. We've got a data analyst that joined us 3 months ago. And it's the first, I'm going to be really honest, it's the first opportunity I've had to really look at our data, what's been going on during the pandemic. I think we've been so blinkered with the pandemic and a shortage in workforce that we haven't really had that look. And unfortunately, it's not as such a happy picture as I wanted. Some of it we know is linked to the pandemic, so prescribing, PPE use, etc. But our E. coli's dipped a little bit, but they've gone back up again. So we know that we need to be doing some big pieces of work. We're unlikely to meet our target for AMR for our 2024. I know it's not just us, but I know I'm having to kind of socialise this with our board at the moment. Hydration. So again, E. coli's is a big problem for us. So even though hydration doesn't solely sit with IPC, we need to do a big piece of work with our colleagues, our continence care. We, as a system, we need to bring everyone together to this working group, this task and finish group that actually is going to do a really good intervention. How do we do it? Bring in our local authorities, because actually what we've identified in North West London is our biggest problem with E. coli is actually people in their own homes. So how do we get people in their own homes to hydrate? In care homes, it's not really a problem. You've got people looking after them, ensuring, monitoring their intake. If they've got catheters, they're doing good catheter care. But actually, it's all our patients that are sat at home who don't like to drink or can't drink. They think that, also, I won't go through all the different problems, that's a complete different presentation. But we need to be bringing in our resources for that to do a big hit. So actually, we think it could have some really good impact. Workforce, I'm going to touch on. We are running out of IPC nurses. We have lots of people that have left or retired. We're not attracting people. I don't know why, but IPC is not sexy anymore. I think the pandemic might have squashed any enthusiasm that anyone had to join. It tends to be the younger people coming kind of just into nursing, go, oh, I quite like IPC. Anyone that's been in nursing a while thinks, no, I'm not touching IPC, thank you very much. So what can we do? Because actually we've got to create a workforce, because actually give another 10 years, if we don't get more people into IPC, we have lost a big resource, and we've already carrying a lot of vacancies, and it's across our organisation. I think it's obviously a national problem as well, so we start growing our own, but I will cover that in a moment. Sepsis, microbiology networks, trying to link in with microbiology. Animal health, you might think, why is that in there? Again, it goes back to our prescribing, our antibiotics. There's no point in us doing lots of work in human health if we're not looking actually what's happening in our animal health as well. Engaging with our director of public health, health and social care. I haven't really even got to voluntary sector yet. These are people I need to engage. I need to identify who they are and what we have in our system, which again is a big piece of work trying to work out a map. And that's how we got to do our networks to find these people. And academic science as well. We've got Imperial, we've got Chelsea within our ICS, but yet we're not utilising the academies there and the kind of the science that we have. So rather than us kind of scratching our heads going, well, let's try and pull some data together, we've got some fantastic people that want to do pieces of work, but we're not communicating with them. So we need to be bringing them in saying, we think we've got a problem here. What can you do? Can you give us some data? This is what we want to find out, and actually utilise everyone in our system and engage, and hopefully it'll be beneficial to everyone. So all of that, hopefully, will work out a better patient flow between services, less healthcare-associated infections, and better compliance and reduction to prescribing are our key aims for the future. So I'm sharing our proposed structure with you. I have kept the bandings in there as well, just because I think actually it's important that I do share it with you. This is my third structure in 2 years, and I worked through this with Gaynor and Linda at NHSEI. Because actually what I had originally was a very kind of, it came from the CCG, yet you've got this amount of nurses and kind of quite low on top, kind of more senior roles. Then we had the pandemic, so we got dropped into the ICS quite quickly and said, okay, what do you need? So again, we were right in the middle of the pandemic. Okay, we think we need this people, but I think we need some more senior people. Actually, when we started looking at our strategy for IPC in North West London, actually, I don't need lots of band 7s and band 6s because actually we're not doing the groundwork as such. I need more leadership. I need project leaders, not the worker bees as such. So we actually created a slightly top-heavy, and some people's jaws might drop when they see the banding, some of this, but the reason we want uplifting to these posts is we want it at board level. So we've got to capitalise on the pandemic. And before it kind of is a distant memory and everything else takes over, we need to make sure IPC stays there. So by inflating these posts, so we've got an executive IPC lead and a clinical DIPSI. This role currently, the executive IPC lead is actually the DIPSI, and the clinical DIPSI is actually the deputy DIPSI. But I've changed this round, and the reason I've changed it round is I have a DIPSI that's not IPC. So they're going off to the meetings, kind of say flying the IPC flag, but not necessarily understanding what we're doing. So then they go back with a question, come back to me for a question. I then have to do some more slides and go back. And I think, let me at them. I want to be up there answering the questions, nipping it in the bud, and it prevents so much work. And actually, we can keep banging on about that IPC message. And I think otherwise it gets lost. So as much as our directors of nursing want kind of IPC in their portfolio, completely understand that. So we've given them the executive IPC lead role, but not a DIPSI role. The DIPSI role needs to be that clinical person that still attends these meetings with them, but actually is getting that message across, answering things, and is keeping IPC on the agenda, which is why it's a slightly inflated banding. So the role of the clinical DIPSI is looking out. So it's not necessarily looking in at your team in North West London, actually what's coming on the horizon. Are we up to date? Have we got assurance? How am I interacting with CQC, NHSE? And we're keeping those conversations open, looking at other ICSs. My Band 8C is the person that's looking after the team, saying actually how are we doing? We're a bit concerned about this organisation, what support can we give them? And then I've got my Band 7s who will be the people who will be managing the projects, looking at hydration, things like that, going into organisations where there's big outbreaks, going into support there as well. And right at the bottom, I've got the IPC practitioner. This is again to do with our workforce. We are running out of IPC nurses. So our Band 6, it's a practitioner, has to be a nurse, it can be an allied health professional. But the key thing is we want to attract someone that's got an interest in infection control. This person sits within our budget, and we'll be paying for them, our team, but they won't necessarily be working with us. So their role will be coming into us, and they'll be moving around different organisations. So if we bring someone that's got an interest in IPC, we'll move them and they'll go in to spend, say, 2 months in one of our acute settings, and then 2 months in a mental health setting, 2 months in primary care, then some time in local authority to make them a really well-rounded IPC practitioner, along with some education to get them a training course. The hope is either they'll progress and get their Band 7, they'll either stay with us, they'll move to one of our organisations within North West London, or they stay in IPC. So even though this is not a definite benefit to us as a system, we're actually increasing people. And as they move on, hopefully we'll then get another person coming in. And it's a model that we hope to then replicate, and hopefully other ICSs might use this as well, because we have to start growing our own. We can't keep pinching different people from the system, because we all start to get to know each other a little bit, and we're like, oh, so-and-so's there. And then you feel really bad when you take one of your acute trust's IPC nurses. But actually, how can we get these people up? So we need a really good education package, but we need them to rotate. So actually, they might go, I really like mental health, IPC. I found it a real challenge. I want to know more about it. Brilliant. We can then support you in your education to that. But you've then also got understanding of how an ICS works, how an acute works, and what happens in primary care as well. We've got a microbiologist, so just 2 PAs a month. It supports me in my team. I don't know the answers to many things that ask, but at least I've got a microbiologist I can go, actually, can you give me your position on this? Can you interpret this data for me? And that's really useful. And a data analyst, I cannot say how much I need a data analyst in my life. Because actually, otherwise, it was used to be me sitting on the DCS system trying to pull data off. It was out of date. I was never quite sure if I'd done it correctly. A data analyst actually understands the different organisms, especially when you're talking about attribution as well, whether it's hospital-acquired or community onset, etc. Actually, to understand that and give us the figures and actually look at the trends, what's actually happening. So forget the pandemic. Can you give me data for the last 5 years? I want to know, actually, minus the 2 years where we had different patients and different prescribing, what happened before? Are we in a better or worse position? And they can give you all that data. And that literally changes my world. I get slides every month that just tells me a story and I can kind of interpret it. And I think, actually, I'm a bit worried about our Pseudomonas. That's really gone up. And then they can do a bit of a deep dive as well. So if you're looking at your structures, the best thing you can do is put a data analyst in there, because they can do what takes me a week, they can probably do in 2 hours. And they do lots of colourful graphs and things like that. So some challenges. So my biggest battle at the moment, and I've even got emails today saying, can you come and do some primary care training, please? No, sorry, that's not our function anymore. We've done it over the last few years because we were supporting you, but actually you need to have your own function in there as well. So it's going to provide us to understand what our role is as the IPC team. Is that strategic function? Feed into us, come to the meetings, make sure you're represented, we'll have the discussions. We're not making decisions for you, making decisions with you, and we'll hopefully then influence board to make sure we can get some traction within our system. I keep mentioning it, keeping IPC at board level. We need to kind of do it now. If we leave it 6 months, a year's time, IPC will be pushed down the agenda. There'll be other things more important coming in, or so they think. But actually now it's time to say we've got the pandemic. As we're kind of exiting stage left of pandemic, we've now got to look at our AMR. We've got to look at all the other bits and pieces going on to make sure that they're well cited. And it's not just data they're looking at, we're telling them a story. Actually, we're in a bad position here. I also use our data analysts to benchmark us against other organisations, which is sometimes really helpful when you get to kind of pitch people up against other people and go, actually, we're not doing so well. North West London like to be a bit of pioneers and like to be the first. If I start saying, oh, we're not doing very well, we're one of the worst, sometimes that gets people's ears to prick up a little bit and we think, actually, let's make a difference. Workforce, trying to get more IPC people. I've carried vacancies in my team for the last 3 years. And it's not just that I can't recruit, it's actually my time actually trying to get people to get adverts out, to go through all the different hoops you have to do with HR. I haven't had the time to do it, it's not been a priority. So I've been my own worst enemy. I've been short-staffed, but I haven't done anything about trying to get people in. And now I am trying to get people in. There isn't anyone out there. So it's making sure that we're developing our own workforce as well as building what we've got already. And I should just say, as I've said to you, I've had 3 different structures. I haven't put my team through 3 different structures. We've always carried vacancies. I've just changed their roles around slightly in case you think I'm a really awful Deputy Dipsy. I haven't done that to them. Harmonisation with local authorities. I've got 8 different boroughs. So one of my boroughs has got their own IPC nurse. They've got a really kind of dynamic director of public health. They want to do everything. It's really, really good. And sometimes I'm thinking, well, slow down. We need to work a system. And I've got some boroughs that I just struggle to get any communication with. So I've really got to try and get some harmony between the 8 boroughs, but also make sure we've got that regular dialogue going as well, and we start working as a system. System working to reduce HCAIs. I mentioned earlier trying to get working with our meds management team. Obviously, AMR isn't just IPC. There's lots of different strands to it. And I want to be working with our meds management. So our IPC group is quite mature now because we've been obviously working in the pandemic and it's forced our hand. Whereas meds management have been very busy doing other things like vaccinations, stuff like that. So we're now trying to pick them back up. So we've now offered to share our meeting, our IPC meeting, with our meds management, our pharmacy, until they've matured, and then they can break away and try and work out the governance as well. So how we interlink. We all feed into clinical governance, all feed into our gold command, but actually how we're representing each other and actually doing objectives together as well. And inequalities within North West London, providers and population. We have got inequalities and we need to make sure that's removed. We need to be looking at everyone within our population, but also our services. Like I mentioned earlier, just because you're in central London, you're next door to one of our really kind of world-famous hospitals, it's not then you're going to get good care. You're going to have the latest information. But actually, if you're in our outer borough next to a district hospital, you should have that equal opportunity to have that care as well. It should be equitable across the system. So that's something we're going to have to do a lot of work with. It's not just IPC, but obviously we've got our part in that as well. So I know I'm running over time, so I'm going to go into our conclusion. So system working is best for our patients. If our patients move seamlessly through all our organisations, we're able to look after them more outside of our acute hospitals. It reduces our HCAIs. It's better for our patients as well. And it reduces the stress. I don't think we're ever going to have a perfect model where literally everyone's like, I love what we're doing in North West London, but I'm hoping we can make some good improvement and actually it will impact our patients. Collaboration will reduce HCAIs. We're all working in silos trying to do different agendas, but actually if we all get together and focus and do one objective at a time, it should have better impact. We should be able to reach more people as well. So oversight of prescribing to support AMR. Again, we just wanted to get our data through now from meds management, and there's a talk on AMR earlier. Within North West London, we've got some areas where we've got real resistance to some antibiotics and some that haven't. So even within North West London, we've got a difference. So actually it's starting to look actually what have we got within our systems? Do we need different interventions in different parts of our systems? Continue with our struggling organisations to support them. It's difficult decisions. This is something that I think as an ICS we've done quite well. We've had to make, as organisations have over the last few years, some very difficult decisions. Sometimes we've sat outside of guidance. And we've had to do it because we had 16 ambulances waiting outside our A&Es. It makes us all, for anyone who's been in IPC a long time, you've always had guidance behind you to say, this is the guidance, and all of a sudden the guidance is there, but you're saying, no, it's not working. And sometimes making difficult decisions as a system is better, and it's nice for our organisations to know that they're not on their own. We are supporting them as a system. We're going to go with it. We've signed it off, and you are supported. So should something go wrong, or you're not going to get the backlash, we're doing it as a system. So there won't be outliers. So it is giving that kind of support, and that's something that's fed back to us. Actually, the system working is supportive to our organisations as well. Working with other ICSs in the region allows for sharing of learning. So even though we are quite a big ICS, I still want to know what the other ICSs in London and the rest of the country are doing as well, because actually you could be doing some really good work. So I want to know about it. So if you are one of my counterparts, another ICS, the chances are at some point I'm going to collar you and say, oh, are you doing anything about this? Because actually I want to know, we don't necessarily think we got it right. I think we're just a little bit further along the road than other people. So actually we could get it catastrophically wrong so far, but actually we're not going to know until we evolve. But if someone else is doing something better, I want to know, because actually we can learn from it as well. And NHSE support in decision making has been really good for us. So when we kind of sit, like we had that conversation, we sat outside of guidance, very nervous. Actually, by going into our regional NHSEI IPC and saying, this is what we're doing, and they go, do you know what? Yeah, I think you're okay. The guidance does say this, but actually you've got other pressures as well. It's that reassurance for us to actually say, okay, if NHSE are kind of okay with it, and we're okay with it, I think we just have to go with it. And we have to be bold and we have to be brave. So that's where we're going forward. So I'm going to wrap it up there, but the key thing is, if you are making any changes within your organisations, looking at your structures, I'd say now is the time to go and make sure you've got that IPC at board level, because I think we need to keep that voice there. It is important, IPC, but we're not just IPC for COVID, we've got other organisms as well and other challenges that we have to deal with. So if we can keep our voice there and keep a good solid team, keeping that information flowing, then it should secure our future as well. So thank you very much.